generous introduction, and thank you very much for giving me a chance here to really talk to you about the JADE program, very much talked about in Asia, but I just thought it would be interesting to really go through the sort of journey. Let me see here, right, okay, so the what, why, and how of JADE. So we are all physicians, we see patients, right, we make decisions, and these observations will actually somehow give us some kind of hypothesis, and then you might want to actually go and prove it. Diabetes is really a classical example of chronic disease. There's a lot of challenges and opportunities. It's silent. The protocol is very complex. It is multi-system. Because it is silent, if you don't measure, you cannot actually monitor and you cannot actually manage. There's a lot of clinical inertia. Person also have no symptoms, therefore they don't adhere. And as a result, many of these people, they relapse, they default, and of course, not to mention that there's a lot of psychological burden because it demands a lot on the person to change their lifestyle, to take medications, to prick their fingers. It is not easy having diabetes. Then in order to cope with these multiple challenges, firstly, as Professor Lee has already mentioned, early detection is critical. If this is so complex, you can't do it all by yourself. You need a team to help you. And in order to really tell people that they have a risk, you have to do risk assessment. And then, of course, you have to give people decision support, what to do when they actually got those information. And feedback is very important. It's very behavioral. We know this is cognitive, behavioral, psychological intervention. One of the most important principles is actually feedback and to empower the person because he or she has to look after himself for the rest of their life, be it 20, 30, 40 years. That's really very important and has to be quite frank to the person. And that sometimes create a paradigm shift. Person come and say, well, you sort me out and not me, doing it. And so that is something that we really need a lot of effort. And finally, I think ongoing support is important. So my journey started in 1989 when I became an academic person. I joined CU, and as a clinical pharmacologist and a diabetologist, the first thing that I was given was a trial. And this was really one of the first Asian randomized placebo clinical trial in Asia. And this was comparing enalapril and nifedipine in patients with hypertension and also hypertension and type 2 diabetes. So I was very junior at that time, so I took the protocol, I designed this case report form, consent form, and I was given just one nurse, and that is actually Margaret on the left-hand side of the top table. We did this in a very small room, which is actually half of the conference room, on the 9th floor of the Department of Medicine. And so we recruited 102 patients, got randomized, but essentially the first year, we actually reported the reduction of albuminuria in the AC enalapril group. These patients were followed for another 3 years, and clearly we demonstrated that there was a decline in eGFR with the severity of albuminuria, but people treated with enalapril was actually had slower rates of decline in terms of eGFR. But what's more important is, while I was conducting the trial, I started seeing a lot of patients actually developing end-stage kidney disease or on dialysis. I was curious about this. How come, I've been following these patients in my little sort of room, assisted by a nurse for so many years, 3 or 4 or 5 years, there was no problem. So I asked Dr. Sowini at that time to go and actually retrieve, age and sex matched and duration matched diabetic patients who were followed up at different clinics. And essentially what you found is that people who were receiving structured care within the clinical trial setting, and those people who were followed up rather randomly in the usual care setting, they have similar age, they have similar disease duration. In fact, they have similar follow-up visit. And of course, half of my patients were actually receiving ACE inhibitors. They were also more high risk because they have hypertension and so forth. However, you could see that actually during that 10 years or so, the blood pressure came down actually in the clinical trial setting, whereas the blood pressure went up in the usual care setting. And so it's also the glucose. And of course, most dramatically, actually, 24% of people died actually, in the usual care setting, as compared to really less than 1% of people. Only 3 people died actually in that cohort. So that was really, for me, quite a sort of, dramatic. And I came to realize that, it was really participating in the clinical trial that have saved these people's life. A clinical trial is characterized by a protocol, by a nurse, by a monitor. And it is really what we want to do. It's not what we want to do, but it's actually the setting which actually frame our behavior. And therefore, I feel that really we need to do something about that. And so this is really, and then when we actually do logistic regression analysis of this cohort, it was really interesting to note that actually the use of structured care in this situation as a clinical trial, nothing too fancy. As I said, I was only a former nurse. And there was 80% reduction in terms of death rate. But even at that time, we could already see the importance of kidney function and glucose in determining death rates and as well as the frequency of follow-up. So it is not just one factor. It is the way how you deliver care, the way how you manage these metabolic factors, and also the frequency of review. So around about that time, that is 1993, there is this International Diabetes Federation, which is a global advocacy body for the betterment of people with diabetes. And they came up with this proposal. They had this St. Vincent's Declaration. And they actually highlighted there is a need to actually do quality improvement program. And basically, at that time, they put forward this diabetes center annual track follow-up in order to implement the protocol. And without going into detail, basically, they gave some sort of concept about, what are the database that we should create, and what are the processes that we should create, and what are the outcomes that we should measure. So I was a pretty energetic lady at that time. So I decided actually to go to visit some of the different centers because I was trying to sort of learn about some of the research methodology like genetics, claim studies, together with Rebecca, who was a diabetes nurse at that time. And so we then decided to do something about the diabetes care in the Prince of Wales Hospital, essentially, really using the diabetes center as the focal point of action where people actually undergo assessment, and from there they are triaged. The assessment and also the education all happen at the diabetes center, which also provide the liaison between the patient and also the care providers. So of course, everything has to be written down. It's complex, as I said, it's silent. And so we actually defined, all the procedures, all the complications, and also the risk factors in order to help, the paramedics to implement this. And so at that time, we actually used DBase, and then later on, it was really access of Microsoft to enter these data and then create, a database, and then with some coding, we use this wealth of data in order to define the complications, the risk factors, and the targets. And after, the assessment, these people come back, even at that time, they come back with a summary of the report. And this report was also going to the doctors. And that was really the beginning of a diabetes register. And at that time, we also started the dialogue, actually, with the primary care doctors, both in the public and also in the private sector. And there were lots of barriers. Firstly, different systems. Okay, they were actually under the Department of Health. They have a very different formulary. We can't even discharge patients, even though they're stable, because they have no ACE inhibitors, because no insulin, etc. So it kind of fed back. Actually, I used to go to the HA conference and then presented this data. And I think, our policymakers and administrators are really very receptive. And they actually, along the way, they actually make it easier for us frontline people to do it. So at that time, we also introduced, for example, a structured referral form so that we can actually prioritize the patients to come to the specialty clinics. So meanwhile, we continue to, as academics, we obviously have to do research, and I have quite a lot of PhD students. And these studies really, reinforce my conviction that the structured care is so important. So we were part of the RENOWN study. Of course, RENOWN study is the losartan that really has changed guideline. And we recruited, we were the top recruiter in this study. And in this sub-analysis in the Asian patients, clearly we could demonstrate that losartan reduced end-stage kidney disease, and the effect size is a lot greater compared to the overall population. And then I asked one of my pharmacy students and to see whether really what the Dr. So has demonstrated indeed could be repeated. And so what Wilson did is actually he plotted the 1-over creatinine before the entry into the clinical trials, and then plotted after entry in the clinical trials. And irrespective of whether they were actually on ACE inhibitors or on ARB or they're on placebo, you could see that the slope of decline of eGFR markedly was reduced upon the entry of the clinical trial. And therefore, we were able to delay the end-stage kidney disease by a few years just because of that. And then at the same time, I also then, Wilson did a really quasi-experimental study. This is really an improvement program, about 160 patients with CKD. These are patients with EGFR 40, and then half of them were actually managed at the center, still seen by me every 4 months, and then between visits, Wilson gave a call, and Wilson reviewed them and also do measurements. And again, you could see that despite the advanced CKD, even within 2 years, there was already a huge reduction in terms of end-stage kidney disease is a true outcome. At the same time, engagement is very important, not just education, not just empowerment, but also engagement. Two of my pharmacists, and they're all now very senior, and we recruited 1,000 patients actually at the outpatient clinic. We took the compliance, and these patients took 5 chronic medications, and 50% of them are not taking it, or they're taking wrongly. We randomized half of these non-compliant patients to receiving a telephone call between the medical visits. And within 2 years, we could see that there was a reduction in 50% telephone call, a 50% reduction in death rates. So engaging the patients, giving the education, don't stop your medications, just lightly. If you have problem, tell your doctor, etc. And I think this really go a long way. And we went on to do multi-center studies, and again, using a doctor-nurse team, treating sort of to multiple targets. Again, these patients have CKD, and again, within 2 years, just can make sure they are on targets and they're put on RAS inhibitors, we can again reduce end-stage kidney disease by nearly 60%. And this is actually verified in our real-world data, where we could see, treating ABC target reduce heart disease by about 60%. So with all these efforts, because of the research and then changing the practice, we were awarded this IDF Center of Education Excellence Diabetes Care, and we were also, very nice of the HA, and then we were actually the best HA program and best HA team. In 2000, this care protocol, was actually adopted into the EMR system, but that's not enough. They've also created career paths for the diabetes nurses, and they created diabetes centers so that, the diabetes nurses would run the center supported by the endocrinologists, and in the center, they do 3 things. They do assessment, they do education, they provide liaison. I want here to really emphasize, I know a lot of people talk about EMR, real-world evidence. Registers is different from electronic medical record system. A register has to be designed, it has to be implemented, and then it will actually combine the practice and the data analytics to actually drive action. In the EMR, you could see that you have very basic information, just age, sex, some of the biochemical values, and then also some of the ICD codes for hospitalization. But what's most important is the baseline data, and if you don't collect that systematically, analysis could be biased. And this is really what makes these registers very powerful, particularly like in Hong Kong when you have a territory-wide electronic medical record system. And then using these registers, we were able to actually start generating a lot of risk equations, and then these risk equations were able to predict end-stage kidney disease, heart failure, and most importantly, you could see there are different combinations of risk factors which predict different outcomes. But very consistently, EGFR and ACR are the 2 most important predictors. So measurement of these biomarkers are very, very important to highlight the risk profile of these individuals. But for those who are more research-orientated, these databases and cohorts are accompanied biobanks, and really, this has become one of the most comprehensive database and also biobanks for a lot of discovery, now actually led by Ronald and his team. So with that, I think 2007, we had an opportunity. We were given a rather generous educational grant, and we decided to digitalize the entire protocol and put it on the web. And at that time, we also incorporate the templates for data collection and also the risk engine. And most importantly, we visualize the data, right? So data collection is just the beginning. And so that was run by the Asia Diabetes Foundation as a nonprofit organization under the COHK Foundation. And you could see that by different combination of this age, sex, disease duration, risk factors, very importantly, EGFR and ACR, complications, and risk scores, you could see that before you triage them, the average incidence rate is about 3% for major events. But then when you actually start triaging them, then you could see that these are 4 levels. Of course, the highest level are those who already got complications. Majority of them are grade 3, and these are people who have got multiple risk factors and CKD, suboptimal A1C and BP control. And then, of course, what we're trying to do is stop people from progressing from 1 to 2 to 3 to 4. And so then after collecting these data, we then actually, create a form and trying to be very simple, giving this color code, and then let people see, whether they are the sort of red bar or they are the orange bar or they're in green zone. Most importantly, these are the only 4 risk factors that you can modify, at least at that time: A1C, blood pressure, lipid, and also body weight. And then you can tell them, where are they at target, so what is actually the target, what is the trend, and particularly there was actually accompanied by decision support, and the decision support for doctors is actually refer them for education, to control and to add, organ protective drug. For patients, the decision support focus on self-management. So, but of course, I talked about the mental burden of having diabetes, and so again, supported by certain grants, we actually decided to embark upon peer support using JADE program. So essentially, in these 600 patients, they were all managed, according to JADE protocol. Under the JADE assessment, they receive a report, and then half of them actually receive telephone-based peer support, So I won't go into the details. It's one of the most fun projects that I had. And essentially, everybody's on board, including the peer leaders. And essentially, what happened is the primary outcome was A1C reduction. The result was negative because everybody improved. And in fact, anybody who used the JADE platform to do clinical trial already, things would improve. So I think that's actually quite useful. But anyway, you could see that the A1C target, blood pressure target, lipid targets has all improved. The adherence rate has also improved. And very importantly, we measure a lot of psychosocial measures that also improved. But what's interesting in this study is actually we found that people who receive peer support actually were more likely to be hospitalized. And this is only after 12 months. And those people who were diabetes distressed were also more likely to be hospitalized. And when we actually overlapped the 4 Kaplan-Meier curve, then you could see that those people who actually had distress and did not receive peer support were the people who had the most hospitalization. So telling us that, we also need to think about this psychosocial support for these people who are very vulnerable. So meanwhile, we actually, implement these studies in about 11 countries, and again, without going into details, so we have about 300 healthcare providers, and some of them are here, and together, sometimes they were given support like a nurse or clerk, and so similarly, they were recruiting like 600 patients, and then again, trying to see whether we could improve outcome. And indeed, we're able to demonstrate, this kind of approach in all kind of setting. In Hong Kong, finally, we did one study, and that is, the different setting is very important, because by then, we already have the RAM program, but at PWH, we still continue to use the JADE report, and then because there were 50% of people working in the private sector, and we want to really give them some support, so we have this Yao Zhongki Center, which is led by the nurse, and basically, people can self-refer or refer by the primary care doctors or private doctors, and they will have a JADE assessment, they will have a JADE report, and then they will have some written comment by the endocrinologist, and then, the nurse would explain the report to them, and then every year we give them a telephone call. Whereas in, at PWH, they get the reports, and then also there was a group education. But in some of the hospitals, they have the assessment, but the follow-up question was not so certain. And what we found is, once again, we could see that there was a triage, in terms of the JADE risk level. So the higher the risk level, the more likely they will be hospitalized. But very important is whether they are actually, if it is in a public care setting, the issue of the JADE report together with the education is associated with reduction in terms of hospitalization and death. And then those people who are receiving JADE care, if they were also receiving public-private partnership, they will also, better manage and have good outcome. So basically, we actually looked at different outcomes, and essentially we found that it's the same assessment, but the follow-up is very important. And then, really, it is the assessment is the first step, and also the setting would have an impact on the people's outcome. So in fact, this was actually part of a public policy research scheme. So I applied to the Public Policy Research Fund and then evaluated this. And with the help of my mathematician, who was a postdoc, who was a PhD student then, we actually analyzed that in this 1,600 patients, actually the public JADE versus the public JADE was associated with 20% reduction in outcome, and then the public-private partnership versus the public partnership was reduced by 60%. Age of diagnosis came out very important, and really, I think everybody knows young patients are the most vulnerable, and of course, those risk levels are very important. And very interesting, personal education is very important. After all, maybe, social care and also educations are part of the premise actually for good quality of life and also good health. And in this very big database, statins always came out to be protective. So based on that, we suggested that maybe we should have all these community centers as well as to have the doctors collaborating and then using structured assessments supported by vouchers, supported by insurance schemes, together with some of this technology in order to make diabetes care more sustainable. And indeed, I think we received a pretty good report from, the assessors, and they said that they should be sort of take notes of and try to implement it. So since then, there's really over the last 5 to 6 years with all the availability of technologies, the next question is how do we make it happen? And so there was a lot of quality improvement program, and this is one of the meta-analysis conducted by Dr. Lim. And essentially, there are strategies that target at the system, at the providers, or at the patients, and they all reduce A1C, they all reduce blood pressure, LDL cholesterol. But the three most effective measures is actually task delegation. In other words, we actually have a team-based management. Self-care really is very important. A relay, either you use information or you use even a community workers to make sure that what the doctor wants and the nurse patients do is absolutely aligned. So recently there was a very huge analysis. This is led by Dr. Magliano from Australia, and we were part of the collaborators. So between 1995 and 2016, there was about 0.5 billion patients here from 16 countries that have got territory-wide register. And so here you could see that Hong Kong and Asia have the largest decrement in diabetes-associated death rate with 4% per year. So I think with that, we put in some of the KDIGO practice guideline and then really emphasizing the importance of using data to drive actions. And depending on the settings, some of these registers can be linked to population statistics, hospitalization statistics to actually inform practice and also policies. And on a local basis, you can use it for multiple purposes, QI, real-world evidence, and discoveries. So, so on behalf of the team, we have actually got some of the award really for this kind of from practice to research and to influence the policy. And so, finally, I really want to take opportunity to thank everybody who were involved in making this JADE program possible. Thank you very much.